Extradural hematoma. Definition: an extradural hematoma, EDH, is a collection of blood in the extradural space above the dura mater. Extradural hematoma, EDH, also known as epidural hematoma, refers to a collection of blood in the extradural space between dura and skull. It is most often due to trauma and commonly associated with a skull fracture, 75 to 95% of cases. Epidemiology of EDH etiology EDH is most commonly due to trauma from a direct head injury. EDH is often life-threatening and patients may require emergency neurosurgery depending on the patient's neurological status and size of the lesion. It is worth noting that the majority of patients with an EDH causing significant mass effect, midline shift or herniation, will likely have a reduced Glasgow Coma Score, GCS, or be comatose and therefore likely to be non-communicative and compliant with examinations. The most common cause of EDH is trauma. This is usually in the form of a direct head injury during a fall or road traffic collision or impact with a high-speed object, for example, cricket ball. Risk factors. The risk factors associated with an EDH include mechanism of injury, fall or road traffic collision, anticoagulant/antiplatelet use, alcohol excess, liver dysfunction, coagulopathy, anatomy and pathophysiology. The brain is encased in three meningeal layers: the dura, arachnoid, and pia mater. In order to understand the anatomy and consequences of an extradural hematoma, we need to understand the anatomy of the meninges and the physiology of the Monro-Kelly doctrine. Meninges. The brain is encased in three meningeal layers, which are the dura, arachnoid, and pia mater, outside to inside. The pia mater is adherent to the surface of the brain and spinal cord. The subarachnoid space is found between the arachnoid and pia mater. The subdural space, a potential space, is found between the dura and arachnoid mater. Pathophysiology. There is impact damage when an EDH forms, which causes the bleed to be potentially lethal. There is often an overlying skull fracture. EDH is most often caused by a fractured temporal or parietal bone, which causes damage to the middle meningeal artery or vein. Rarely the source is the dural sinus. Blood then accumulates between the dura and the skull. EDH tends not to cross suture lines unless a previous craniotomy or procedure has disrupted normal anatomy. Furthermore, EDH are not routinely seen in elderly patients as the dura is often adherent to the bone and therefore there is less potential space. Monro-Kelly doctrine. The Monro-Kelly doctrine states that the skull is a closed vault and the sum of the brain, parenchyma, cerebrospinal fluid, CSF, and blood is constant. It is a pressure-volume relationship. If one increases, then either or both must decrease in order to compensate. In the case of an EDH, the presence of extra blood exerts mass effect, and this can be potentially lethal as it can cause compression. Therefore, the operative management involves a procedure called a decompressive craniectomy or craniotomy to relieve pressure, evacuate the blood clot, and stop the bleeding. Traumatic brain injury, EDH, falls under the umbrella term of traumatic brain injury. EDH is uncommon but complicates 1 to 4% of traumatic head injuries. Classification T. BI is a heterogeneous term with many different ways to classify the injury. For example, clinical severity, mechanism of injury. Traditionally, TBI is classified according to the Glasgow Coma Score, GCS, GCS 13 to 15, mild TB IGCS 9 to 12, moderate TB IGCS less than or equal to 8, severe TB I sequelae. Classic pathological injuries associated with TB include skull fracture, extradural hematoma, subdural hematoma, SDH, subarachnoid hemorrhage, SAH, intraparenchymal hemorrhage. Cerebral contusion. Clinical features. Patient usually present with a headache or decreased level of consciousness. With an EDH, there may be a classical history of a brief loss of consciousness followed by lucid interval, then obtundation. This is not always seen. In fact, a lucid interval may occur with a subdural hematoma, and therefore it is not a distinguishing feature of EDH. If they had a significant trauma, they might already be intubated, ventilated, and sedated pre-hospital. If they are alert, they may have the following features: symptoms: headache, nausea, vomiting, seizures, speech difficulties, signs. Reduced level of consciousness, GCS, altered mentation, confusion, focal neurological deficit, for example, weakness, anisocoria, unequal pupils, signs of herniation, fixed and dilated pupil, CSF leak, if concurrent skull fractures. Due to the size of EDH, there is sometimes compression of the contralateral cerebral peduncle, and this can cause ipsilateral weakness, right-sided EDH causing right-sided weakness as opposed to left. This is known as Kernahan's phenomenon. One can only perform a neurological examination if the patient is alert enough. If the patient has a reduced GCS or is already intubated, ventilated, and sedated, the only clinical correlates for brain activity are pupillary response. Note, EDH are not confined to the cranial vault and can happen in the spinal cord as well. Glasgow Coma Scale. The Glasgow Coma Scale is a clinical scale used to reliably measure a person's level of consciousness after a brain injury. It is important to be familiar with the Glasgow Coma Scale, GCS, which is measured from 3 to 15 and has 3 elements: motor response, 1 to 6, verbal response, 1 to 5, eye response, 1 to 4. Please remember, the best possible score in each category is recorded and one has to adapt. For instance, if the patient has weakness on one side, you can assess obeying commands by asking the patient to stick out their tongue. Diagnosis. An urgent NC-CT head is the investigation of choice for the diagnosis of EDH. Always inspect bony windows, as there is often an overlying skull fracture, EDH on CT-CT head, showing a right-sided extradural hematoma and associated skull fracture. Note the classic biconvex shape. Management. The management of EDH has several key elements: 1. Resuscitation, 2. Initial management, 3. Medical management, 4. Surgical management. Resuscitation. The team will complete a rapid assessment following the mnemonic C, ABCDE, with attention paid to control of any catastrophic bleeding urgently. The patient is stabilized, undergoes urgent investigations, for example, blood gas, and will usually have a CT trauma series. An EDH may be suspected clinically and will be detected on CT. Stabilization involves control of any further sources of bleeding, any coagulopathies, and any acid-based disturbances. If other systems are compromised, such as breathing, chest drains may be inserted or pelvic binders may be applied. It is important to remember a patient usually won't be rushed for surgery until they are stable to be transferred to the scanner and theater. Initial management patients with an EDH can present alert or in a coma. This is assessed using the Glasgow Coma Score. A systematic ABCDE is utilized in emergency settings as discussed in resuscitation. If the patient has a low GCS, less than 8, they will require airway management. Medical management. A patient presenting with a suspected EDH should be monitored closely with neuro observations. The expanding hematoma can be lethal and lead to death, which requires immediate operative management. Small extradural hematomas may be managed conservatively with interval scans and assessment of neurology. If admitted to the intensive care unit for intubation and ventilation, neuroprotective measures may be adopted to maintain an appropriate intracranial pressure, ICP. Neuroprotective measures: normoxia, maintaining normal oxygen saturations; normocarbia, carbon dioxide can be altered if ventilated; normothermia, maintain normal temperature; adequate sedation and paralysis; intracranial pressure, ICP. Monitoring ensure less than 22 millimeters of mercury, ICP management. Medically, ICP can be managed using hypertonic saline 3% or mannitol. Mannitol is not commonly used but may still be mentioned in guidelines. These agents do not cross the blood-brain barrier and are able to draw out CSF and reduce ICP. Seizure management. Agents such as levetiracetam, Keppra, may be given to manage any seizure activity due to direct cortical irritation by the blood. Surgical management. Urgent neurosurgical intervention may be warranted in the following situations: significant mass affect or midline shift, fall in GCS anisocoria, fixed and dilated pupils. Persistently raised ICP patients require decompressive surgery to remove the blood clot, and the source of the bleeding needs to be found and stopped. The skull bone may or may not be replaced. Patients are then usually managed on intensive care.